we have a sense in medicine to when we read it in a textbook, it feels like it's dogma, that this is the way it is. And I think there are still things that we do not know about sodium, and we should come at this topic with a little bit more humility and a little bit more understanding that, hey, this stuff is hard. It's not all figured out. We're doing the best we can, and kind of understand that, we're not great at it.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Cyrus Askin.
And I'm Dr. Nick Mark.
So after having totally botched the initial steps of this recording, we've finally gotten the show on the road here. I figured out that you're supposed to actually hit the record button and not the leave button, so word to the wise there. Anyway, without further ado, we're going to be talking about hyponatremia today, a very important topic for those of us that work in the ICU and take care of critically ill patients. And we could not think of a better person to join us on this episode than the great Dr. Joel Topf, aka @KidneyBoy, a bona fide nephrologist, physician educator who I have had the distinct pleasure of working with in the past on other projects with the curbsiders especially. So super excited. Nick, why don't you tell the audience a little bit about Joel?
Yeah, so where to begin? So we're incredibly excited to have Joel with us on Critical Care Time. He is indeed a nephrologist, a prolific medical educator. He's authored multiple textbooks, at least one of which I have behind me somewhere on that wall. He's the co-founder and president of NephJC, a great example of a flipped classroom for discussing nephrology literature. He hosts the Freely Filtered podcast, which you should all go subscribe to and listen to. And he's got a great blog, The Precious Bodily Fluids, which is both a great nod to fans of Kubrick and people who find themselves baffled by homeostasis. He's also a great Twitter follow. He shares a lot of great stuff under the handle @kidney_boy. Welcome to the show, Joel. We're really excited to have you.
Awesome. This is great. I'm pretty excited to be here. But if you wanted better people for hyponatremia, you could have texted me. I got to give you a list of people. It really shows a tremendous lack of imagination that you just came up with me.
Well, I mean, it's Kidney Boy, it's like, it's too easy.
We've got a whole periodic table of elements. We can text you about, magnesium and phosphate and stuff.
Oh yeah, you do not want to get into the magnesium literature. There be dragons. It is a wild literature. Stay away.
Oh God. Yeah, I think probably sodium is a good place for us to start. At least as good a place as any.
Oh, it's excellent.
Yeah. Yeah, I think sodium is both a common problem that our listeners deal with a lot, but it's also a potentially very serious problem. So it's a great topic, for the podcast. Joel, I think you and I talked about this before, but like one of the things we aspire to do on Critical Care Time is sort of do critical care teaching for everyone who takes care of the critically ill, whether you are an intensivist, an ER doc, an ICU nurse, a hospitalist who takes care of sick patients. And this is a great topic that sort of transcends all of those physical boundaries in the hospital. People with hyponatremia are ubiquitous, right? So we can give something for every listener here, I think.
Yeah, it is by far my favorite lecture. It is awesome, and especially hyponatremia. Yeah.
All right. I think on that note, we can go ahead and get started. All right, Joel, so let's go ahead and lay some groundwork for our discussion via a short case. So let's say we've got a 60-year-old man with chronic alcohol abuse, history of chronic alcohol abuse and known cirrhosis. He's found down, brought in by medics, vitals are stable, and he's now awake and alert, but he's a little confused. Lab work is unfortunately notable for a sodium of 114 milliequivalents per liter. So right off the bat, I'll ask you some basics. What is hyponatremia, or how is it defined clinically? And then what are some common etiologies that our listeners should be aware of?
Yeah, so mainly what you need is you want to take a look at the sodium in the EHR. And if there's an L next to it, you've got hyponatremia. It's a pretty simple. Done. Sodium less than 135, that's going to be hyponatremia. And and this patient has got, he's got a history of cirrhosis, which is an important cause of hyponatremia. He's got a history of alcohol abuse, which is not only a known cause of hyponatremia, but also an important risk factor for osmotic demyelinating syndrome. And then he's got altered mental status with a severe hyponatremia. We define severe hyponatremia as a sodium less than 125, and he's well blown past that. So this patient, it's just got a lot of alarm bells going off in my head.
Got it. Got it. And, another kind of a couple of follow-up questions, I guess, for that would be, given that he's only a little confused with a sodium of 114, and I realize that's somewhat vague, but, he's not obtunded at 114. What do you make of that?
Again, I have the problem with sodium is there are no specific symptoms of hyponatremia. It's not like you can take a look at an EKG and find classic EKG changes like we depend on with oftentimes rely on or help us in the evaluation of potassium. We don't have that here. Like, we've got a bunch of nonspecific symptoms: nausea, vomiting, altered mental status, seizures, and there are protein causes of all those problems. And the question always is, well, is it due to the sodium or is it due to something else? And I think until you get proof that it's due to something else, you've got to assume that it's going to be due to this guy's severe hyponatremia.
I think that seems very reasonable. And, Joel, we've talked about, I remember in previous episodes, we've talked about AKI, and I remember with AKI, the big takeaway from that talk was, 90% or many, many cases of AKI can be treated with a liter of NS and a Foley catheter. It was very simple, and I thought it was very elegant. Now, I've certainly sat in many a lecture, whether it be at the bedside or in the lecture hall, where the same slide or some facsimile thereof, breaking down hyponatremia into the various etiologies, has been displayed. How much, how important is it for us to really go through those steps and break it down? And is that actually critically important? Is that just kind of being scholarly? I mean, how do you look at that question?
Yeah. So, I think there's been a lot of ink spilled on trying to make hyponatremia simple. And I just don't think it is simple. Like, I think it's actually a pretty complex disease. And I really think that attempts to simplify it kind of squash the field into boxes that can't contain it. And I think you get a lot of generalizations that are oversimplifications. I mean, the simplest one is always the first step is, check the osmolality to make sure you either have hypotonic or isotonic or hypertonic hyponatremia, right? And so, and the classic interpretation of that is if it's low osmolality, then you got a true hyponatremia. If the osmolality is normal, then you have some kind of lab artifact or pseudo hyponatremia. And if it's increased, then you have the increased glucose causing hyponatremia. But that's a classic simplification because you're categorizing it based on tonicity, but you're not measuring tonicity, you're measuring osmolality. And so you can get a patient who has a high osmolality, but that's due to either urea or alcohol, and they do not have elevated glucose or mannitol or radiocontrast media that's causing it, which are the classic causes of hypertonic hyponatremia. And that's just never taught. It's eliminated as, oh, that could never happen, as if alcohol and hyponatremia are an unusual co-occurrence, right?
Right.
It's actually a common co-occurrence.
Right. That's the PB&J of ICU admissions.
Yeah, that's right. And that it's not addressed in these algorithms because they want to simplify and just eliminate the difference between tonicity and osmolality. I mean, I just like what you're lulling learners into a false sense of simplicity. And I think that's actually the most dangerous place to be. I'd much rather the person be more nervous and say, you know what, I don't quite understand hyponatremia and I'm going to reach for help, rather than saying, hey, I got this algorithm and it's pretty straightforward. I need to do this, and I've got it all figured out. That person, I think, is going to be in more trouble.
Yeah, I'm sure, Nick, I'm sure you've got some questions that you want to get to, and we can discuss this further. Before we get too much further out, I did want to hammer on one point, Joel, and that's that idea of tonicity versus osmolality, and how I think often that's not really considered appropriately. But my understanding is when we talk about tonicity, we're talking about those solutes that are not going to easily cross cell membranes. They're actually going to affect water movement. Whereas osmolality, when we talk about that, we're really focusing more on what are generally ineffective osmoles.
Well, it's both. The osmolality is all of them. It's everything.
Okay,
included.
sure.
So it's going to be your sodium, your potassium, your glucose, which are effective, and it's going to be your urea and your ethanol, which are ineffective osmoles.
So more of a catch-all term then.
Yeah, and honestly, osmolality is what we can measure. There's no clinical measurement of tonicity. You can't order a serum tonicity study, right? We can estimate it. We can take, glucose divided by 18 and 2 times the sodium, and that'll be close to your tonicity. But we don't have a way of measuring it clinically.
Beautiful, beautiful. Yep. See, and I goofed it up there myself. So thank you for clarifying that. Nick, I'm sure you've got plenty you want to talk about, so I'll shut my mouth for a little while.
I mean, I think there's a lot we could talk about regarding testing and workup.
Yeah.
And I think this is a point of common tension between the emergency room and the admitting service. Like, the ED doesn't send labs, they give some saline, and now our labs are, quote, uninterpretable. What are your thoughts on that, Joel?
Well, the best time to get the urine studies and the serum studies is right on admission. The second best time is right now, right? So don't delay because the patient's gotten a liter of saline, or they've started on IV fluids, or we don't have that initial urine specimen because it was tossed away. Getting that right now can be informative, right? It may not be, but it's better than nothing, and it's going to give you some kind of traction. And honestly, I think, in terms of urine lights, oftentimes these diseases are complex, and you will have a couple of different conditions overlapping. Oftentimes you'll see patients that'll be volume depleted, and then you'll correct that, and they'll get this initial increase in sodium with the saline. You're like, I got this all figured out. And then 2 days later, that sodium starts to drift back down with that same saline that had been getting them better. And actually, you had 2 conditions. There was initially some volume depletion, and now you've kind of uncovered some underlying SIADH. And I see that pretty commonly. Again, not addressed in the algorithms, right? They're gonna leave you high and dry on that type of patient. But assessing that, getting a daily, urine panel, urine sodium, urine potassium, urine osmolality on the daily can be helpful.
Excellent.
Great. Yeah. So perfection is the enemy of good. Just because the labs weren't gotten the moment the person rolled into the ED doesn't mean there isn't value in checking them again. And often there's value in checking them multiple times because there's multiple things. I'm just thinking of Hickham's dictum that a patient can have as many problems as they damn well please. And it's not uncommon to see patients who are on a combination of medications, underlying conditions, and their volume status all causing perturbations in sodium.
Absolutely.
Another thing I take away from this discussion is getting the labs is, of course, important. It's going to help inform our decisions. But at the end of the day, if you look at those labs in a vacuum versus looking at the patient clinically and getting a good history and figuring out, okay, based on their history and their clinical presentation, what is most likely going on? That may be a little bit more of a North Star, if you will, at least initially, than really focusing fully on the labs themselves, getting confused in the context of the patient's history. And then you're like, man, do I follow the labs? Do I follow the history? I've seen that before. And based on our discussions in previous podcasts, I've just taken away treat what you see, treat the patient based on their history and the clinical findings, and then adjust fire as needed.
Yeah, Cyrus, I want to be careful right here because, here's a classic one. Patient has a sodium of 116 and they have a history of nausea and vomiting. And you're like, nausea and vomiting, they're volume depleted. This is going to be volume responsive hyponatremia. Or they have some kind of gastroenteritis, which is causing nausea and vomiting. And nausea is one of the most potent stimulators for ADH. So they actually have SIADH. Or they have acute hyponatremia, which is caused increased intracranial pressure when that's causing the nausea and vomiting, right? You don't know if the nausea and vomiting is a result of the hyponatremia, is causing the hyponatremia because of volume depletion, or causing hyponatremia because of non-osmotic release of ADH. That's a case where the story leaves you nowhere, right? It just doesn't help you, right? Yeah. And I think that's the kind of thing that you can look at that. And again, depending on your level of knowledge, your level that you're going to trust your story, you can be completely off on the wrong course. And that's a situation where again, probably if the patient has increased intracranial pressure, there'll be other findings that you'll be able to rest your hat on, other parts of the story that'll be consistent with that, whatever, it's an acute water intoxication, an ecstasy ingestion, that'll lead you to that acute hyponatremia, or the volume depletion, you'll be able to back that up with your physical examination. But you just got to be careful that it's not, these things are, like I said, this disease is not as easy as the algorithms make it look.
It's a cautionary tale, Joel. Thank you for walking us through that.
Yeah, I think let's turn now to kind of one of the controversies in hyponatremia. As listeners may recall from House of God, right? The fifth rule is placement comes first. And so, we've just gotten the phone call from the ED. This person is down there with a sodium of 114. Obviously, they need to go to the ICU, quote unquote. What are your thoughts on disposition? Like where should people go based on their sodium? And recognize that this is controversial and not necessarily guideline based.
Yeah, and I think that's the issue. That a lot of it is like, do you know your own hospital, right? Like, like we have a pretty good step down unit, and they get pretty good care in the step down unit. But if I'm going to be doing a Ddavp clamp, and this patient, he's got altered mental status. I don't know what his potassium is, but he has alcoholism and malnutrition and liver disease in his history, which are all risk factors for osmotic demyelinating syndrome. That's a patient that I may very well pull out a Ddavp clamp. And to raise the sodium, once you've clamped them, you need to give them 3%, and that's going to push me into the unit, right? Our hospital recently removed the requirement for a central line, but a lot of places still require a central line, foolishly, for 3% saline. And, that's going to push you, again, sometimes where they land is going to depend on the therapy you're going to be providing, right? You're going to be providing 3%, okay, you got to be in the unit. Like I said, our hospital's got a pretty good step-down unit. If I wasn't going to use 3%, I'd be comfortable putting them in a step-down unit. I don't think anybody with a sodium south of 120 should be just managed on the floor. That seems like a recipe for disaster. And I think, one of the things that I like to think about is like, well, what's the downside here? What are we trying to avoid? And we're really trying to avoid iatrogenic injury. And for whatever reason, hospitals are much more terrified of iatrogenic injury than just natural history of disease injury, right? Where if it's something that we're doing, if we're correcting that sodium too fast, that seems like more of a tragedy, kind of the do no harm being overturned there.
Great. And so it sounds like the big reason why this person should be in the ICU is because they're likely to need therapies that can only really safely be given there. I'd also add to that maybe that like having a lower nursing ratio means that the nurses will be more on top of their neuro exam, making sure those labs are drawn on time and noticing if we're deviating from the correction, as opposed to like a very busy medical ward where that just won't happen potentially.
Right. So again, so the alternative, the flip side, you're not going to use a Ddavp clamp because you think Toph's crazy. So you're going to use a reactive strategy. And so you have an order there. Hey, give me a call if the urine output goes over 100 cc's an hour. Good luck if they're a floor patient, right? Maybe at the end of the shift, somebody's going to total up the urine output, because the nursing assistant's been totaling up the urine output on a side little piece of paper and is going to enter it into the EHR at the end of the day. You're 8 hours behind, right? And so, in ICU, they'll be watching that hourly urine output, and that order will be addressed.
Perfect. Yeah. And I think sometimes organizationally there'll be pushback about somebody with a low sodium who's not altered going to the ICU. But I think that's the key point, which is that there's a lot of potential for iatrogenic harm, which, I think probably rightfully we view as much worse than just the natural history of disease harm.
Guys, great discussion on disposition. Now, earlier in the episode, we sort of hinted at the idea of having a framework to approach hyponatremia. We talked a little bit about some of the labs. We talked a little bit about how complicated it can be. Joel, why don't you throw some meat on those bones for us and really flesh out how you approach, logically, the hyponatremic patient?
Right. So we talked about checking the serum osmolality. I think that's a reasonable thing to do. And I think we should circle back to pseudo-hyponatremia, but I don't want to get distracted by that. I think that ends up being a super rare occurrence. It is a kind of a once-a-year diagnosis for me, maybe, and it causes a lot of confusion, and I just think there's low yield there. And most of the cases are going to be true hyponatremia. They have a low tonicity and a low serum sodium, and that's going to be the meat on the bones. And I think after that, you want to kind of establish your neurohormonal state. And there's two ways to do that. One, you're going to check your urine osmolality. Two, you're going to check your urine sodium. Okay, so your urine osmolality is going to be your ADH dipstick. And what you're trying to do is ADH is on or ADH is off. And that's how I divide my approach to hyponatremia. I got some patients that have ADH off and some people that have ADH on. And ADH off is an unusual occurrence in hyponatremia, right? When you have ADH off, you're going to be making a large volume of dilute urine, and that is how you protect yourself against hyponatremia. So it's a weird situation to be having the body responding to hyponatremia normally, yet you still have persistent hyponatremia. In that situation, what do you got? You got somebody who's a psychogenic water drinker, right? So just primary polydipsia, drinking tons of water. that's gonna trigger it. But and honestly, with intact kidneys, you're talking about 18 liters a day or something like that. Like, it is a full-time job. You're drinking a ton of water. Okay, so that's one of those causes. Then there's the person on a low solute diet, which is an unusual circumstance in which the solute that's excreted on a daily basis ends up limiting total urine volume. It requires an unusual diet that is almost entirely carbohydrate.
This is the classic tea and toast story.
Or beer drinkers' potomania, both of them.
Right.
Are they really the same disease, low solute diet, and that limits the urine output, so that the urine output will limit to a couple of liters a day or 3 liters a day, and that also becomes a volume that can be achieved by just normal water drinking, and you can get progressive hyponatremia. And then the other one would be partially treated. So you got somebody who's got volume depleted, they've gotten a couple of liters in the ER, and then you check the urine osmolality, and it's low because they're in the process of rapidly correcting. The only other non-ADH dependent one would be a patient who has oliguria due to kidney failure, right? So whether it's acute or chronic, they can only make 200 cc's or 400 cc's of urine a day. Well, they're going to be drinking, they easily will overcome that amount of water excretion with water intake, and they will also can get progressive hyponatremia, right? So those are your ADH independent. They will tend to have dilute urine. The renal failure patient may have urine osmolality close to plasma because they don't have functioning tubules that can concentrate it. But usually you're not figuring out that they have renal failure because their sodium is low. Like, you have some idea that you have kidney failure by the creatinine and the BUN, and that shouldn't be a mystery. And then the other one's going to be the patients that have the elevated ADH, the ADH-dependent hyponatremias. And there, the urine sodium is super helpful, because that's going to detect whether your renin, angiotensin, aldosterone system is activated or suppressed, right? And if it's activated, those are going to be the patients that have decreased effective circulating volume, whether that's cirrhosis or heart failure or volume depletion. All those will have a low urine sodium. Or you're going to have patients that are essentially euvolemic, so their renin, angiotensin, aldosterone system is suppressed, and those are going to be your patients that will have syndrome of inappropriate antidiuresis, or SIAD. And that's the framework that I use. I was like, give me a sense of what these two central hormones for renal handling are active: ADH and my renin, angiotensin, aldosterone system. And you can get that with those two conventional labs: urine osmolality and urine sodium.
And importantly, you can get those results quickly too.
Yeah,
that's right. You're not waiting for a renin activity level, right?
Yeah, geez. Yeah, no, it's helpful to have labs that are practical in our armamentarium. So definitely good to know.
So now that we've talked about sort of that initial framework, and by the way, great overview of kind of the landscape of hyponatremia, what are your kind of first steps in management? Like, let's say you've sent off those labs. Are you going to order 3% in somebody who's altered with hyponatremia like this, or are you going to wait?
So, the first steps are always going to be just stop whatever the ER is doing, right? Stop the saline, put the patient on a fluid restriction. But if patients have altered mental status, that's a sign of a severe symptomatic hyponatremia, and I'm going to start them on a little bit of 3%, or if they've gotten some saline in the ER, I kind of see what the response to that is, because that's a therapeutic test, right? If you've given the patient a liter or two of saline, repeat the sodium, right? Because that may be getting things better. That's going to be an indication of volume depletion or some kind of volume responsive hyponatremia. And again, if it's working, keep doing it as long as it's not going too fast. Right.
And I'll just say that one of my favorite things about caring for these patients in the ICU is that we have point of care testing. So we can do a small volume blood sample and do it on an iStat analyzer and get a sodium in 2 minutes. So, it's much quicker to make that determination of, are things getting better, are things getting worse than it used to be.
Yeah, that's a really powerful tool. Just the only caution there is don't mix up your whole blood sodiums and your serum sodiums. Like, pick one and stick with it, because you'll see variability between those two. And really, we're really talking about movements of 2 or 3 milliequivalents per liter is what you're basing your decision on, and that could be the difference that you would see by changing modality. So you want to pick one modality and stick with it. But having point of care is a really powerful tool.
I cannot I cannot smile wide enough having heard you say that, because I know I've run into this issue before where you're getting like Q2 hour sodiums, but one of them is point of care and one of them is sent to the lab. And you're like, holy moly, like it's just kind of going up and down, not by a lot, but just enough. So you're like, what the heck do I do with this? Just make it easy and just stick with one test. The point of care testing is in the ICU is faster and why is there any reason to not just stick with that?
I was going to ask you to double click on pseudo hyponatremia a little bit. I know, as you said, this is a rarity. I guess my first question is, you hear a lot of stuff about with modern lab testing equipment. First of all, is this even still a thing?
So the answer is you got to dig deep. You can't, if you can't call the lab and say, hey, do we do direct ion detection? Because that's not enough of the answer. Because even with some of the selective electrodes, ion electrodes, they still will do dilution as part of their technique. And if they're doing dilution as one of the steps, then they're going to be susceptible to patients that have high lipid content or high protein content in the blood, just like the kind of the classic indirect ion detection systems. And so it doesn't get you out of jail if they have a selective electrode. Yeah. So you need to be more sophisticated, and it's going to oftentimes depend on the analyzer, and it might be difficult to get the answer because it's all done, in a black box, and the technicians or the people that are answering the phone may not have that answer for you. And so it can still be a thing, even with modern techniques, though you're using whole blood and you're doing for the iStat, I think you're good.
Right. And I was going to say that whether you're using a point of care blood gas test or just a lab blood gas test, that's not diluted and it is ion selective. So that should be robust to this. So if you if you sent like a basic metabolic panel to the lab and the sodium came back super low, but then you sent a VBG to the lab and that sodium came back normal, one interpretation of that situation is this is pseudo and the blood gas is not affected by it, but the classic lab test is.
Mark, Nick, I'm exactly right. Yeah, I would agree completely.
Perfect.
Awesome. Okay, I think that's a perfect summary of pseudo. It still exists. Be aware of mixing and matching tests and know which test is going to be robust to it. Probably the next controversy, and probably the big controversy of this episode that we should talk about, is correcting hyponatremia. How fast is too fast?
Yeah, this one. So this is what happened. I think the reason it's a controversy is because we have not done definitive studies that we have determined. We've learned everything we've learned about osmotic demyelination syndrome either comes from animal studies, which were limited and small, or have been done from retrospective analysis. And had this initial observation in the 80s, maybe a little earlier than that rapid correction of hyponatremia greater than 12 milliequivalents per liter per day was associated with this devastating neurological complication of ODS. And this complication of ODS was initially diagnosed by autopsy. And so you get this wild diagnostic bias, right? Because all the patients that had the disease were dead because they were diagnosing it by autopsy, right? So we had the sense of this must kill people and didn't get a sense of that actually maybe not so toxic. And now that we have CT scans and really MRIs especially, we're finding a lot more. Not finding a lot more cases. We're finding more cases, but we're finding a lot better outcomes. Patients with full, complete neurologic recovery, which was not what I was taught in medical school, right? These were all devastating cases with paralysis, etc., usually patient dying. And that's not the case in modern case series where oftentimes most or nearly all get completely better or largely better. But I don't want to soft shoe this. This is still a terrible iatrogenic complication that you never want to see, and some patients have terrible outcomes. But all we have is this retrospective data and no prospective data that comes out of it. And so the two large accepted guidelines for hyponatremia, there's an American guideline and a European guideline. The European guideline comes from the Intensive Care Medicine Society and the Endocrine Society, right? Nephrologists don't get involved in hyponatremia in Europe for whatever reason. And in the United States, it was largely gang of nephrologists that came up with this, the Verbalis guidelines. And they're largely in agreement, some subtle differences, but they're both looking at 8 milliequivalents per liter change in the first 24 hours. The American guidelines add that if this is a patient that it's at high risk, that you want to shoot for 6, so that if you spill over a little bit, you'll still be in the safe range. And so this has been kind of accepted as standard of care without prospective data to guide it or to verify that this is the right thing to do. Lots of people say, hey, we see a lot less ODS than we did in the 80s. And that very well may be true, but in the 80s, there was really no guidelines and people were treating this as quickly as possible. And I'm not sure, does that mean 8 is right or is 12 right or, hard to know. There are some series that show people that have higher risks of ODS with 10, but we still see patients with changes in sodium less than 8 that get into trouble. And so, it feels to me like the evidence base is insufficient, and I would like to see more. Because this is costly, right? In terms of the amount of ICU time, the amount of time people are in the hospital, the amount of intervention that we're doing on patients to try to keep the sodium regulation going well. And I will say that we're terrible at it. Right. Probably the best study on this was a study by George looking at patients, I think, in Western Pennsylvania, and 40% of patients were their sodium was corrected too quickly.
Right. And I think it's really interesting to sort of, think about these trends. So as you said, the initial description in the New England Journal in 1986 described this as a complication that occurred in people who corrected by greater than 12 milliequivalents per day. And that has slowly over the years turned into a guideline recommendation of no more than 8, or if they're very sick, 6 per day. And so we've gotten much more conservative with our guidelines. And maybe as a result of that, we find that we're actually probably breaking those guidelines more often. Like as the guidelines get more conservative, it gets easier to exceed that rate.
Mm-hmm. That's right.
Yeah.
And what we've seen in this year was a couple of studies that looked at the rate of ODS. And I, full disclosure.
You were an author on one of these studies.
I was an author on one of these studies. That's exactly right. And we've just found incredibly low rates of osmotic demyelinating syndrome. And, so the study that I was done was from 5 hospitals in Toronto. We looked at 20,000 people with sodiums less than 130. That was actually one of the things we got criticized for, that looking at the rate of ODS, including patients with sodiums in the 120s, was kind of a fool's errand. This is what the critics said, that those patients had very, very low rates of osmotic demyelinating syndrome, though we found 12 cases of osmotic demyelinating syndrome, some of them in that 120 to 130 that's usually ignored and not studied, most of them below 120. But the rate, when we had 20,000 people, we found 12 cases at 0.05%. Like this is and we found a very high risk, overall 18% of patients were treated too fast. But if you started to drill down in terms of the low sodiums where the patients were at higher risk, that rate went way up. Hold on, let me get the exact numbers. So overall, it was 18%. 3,600 people were overtreated. But if you look at patients with a sodium between 120 and 130, it was only 13%. 110 to 119, it was 46%, very similar to the George study from Pennsylvania. And less than 110, this is the patients at the highest risk of osmotic demyelinating syndrome, 70% of patients were breaking that speed limit of 8 milliequivalents per liter. I mean, this is just, if this is what we're supposed to be doing, we're really bad at it.
It makes me feel better that we have such a large pool of data that demonstrates a fairly low occurrence of this devastating disease, when a lot of our time in hyponatremia is spent, at least for me, I get very, very nervous as we're approaching that kind of like 8 milliequivalent mark. And I'm like, oh my gosh, what am I going to do? Am I going to, lock in this person? My takeaway from this and from our discussion is, absolutely, this disease is no joke. You certainly want to do everything you can to mitigate against overcorrection. But perhaps if you shoot for 6 to 8 and you end up with 9 or 10, the preponderance of data is supportive of that being okay.
Or you'll probably get away with it.
Or you'll probably get away with it.
99 out of 100, you'll get away with it. But,
right.
you know.
But just to double click on that point, because I think, you know, I'm trying to remember the details from that paper, but I think you guys showed that there were even some cases of ODS that didn't break the speed limit, like people with a correction as low as 4. And that's kind of terrifying to me, because it kind of implies that there are people where you could do everything right and this devastating thing will still happen. What are your thoughts on that?
So we had 12 cases of ODS, and if you divide them based on the rate of correction, so we had 7 cases where the rate was less than 8 milliequivalents per liter per day, and we had 5 cases when the rate was greater than 8 milliequivalents per liter per day. And so based on that data, we interpret these data to indicate that in most cases, 7 out of 12, rapid correction of serum sodium is not causally related to ODS, right? Because we had more cases with this slow rate of correction, this target rate of correction. This was, people were very upset with this sentence, this one sentence in the article. Again, you know, what are we going to do? We're going to report the data that we find, right? You know, so yeah, some people seem to get, you know, people with these high risk factors with, you know, severe hyponatremia. They have bad alcoholism, bad liver disease. People are at high risk for this. And, you know, there are reports in literature of people with no changes in sodium. They get osmotic demyelinating syndrome. And so, no, it's true. I mean, this is not, you know, so it's not just sodium. There's other things that can cause this demyelinating syndrome. It is complex. I don't think it's fully understood. And this is why just accepting these guidelines without getting more granular data and probably prospective data, I think is important.
And maybe we should double click on some of those other risk factors a little bit more, because I think that's something we tend to fixate on sodium and ODS. But as you said, many cases of ODS, it's probably these other factors that are playing a big role. So like, and I know Cyrus wants to ask you about potassium here, but like what are the big factors that go into ODS?
The common stories all the time are alcoholism, malnutrition, cirrhosis, and hypokalemia. Those are the ones that come up over and over again. As being the primary risk factors. And then I would also say severity of hyponatremia is super important, right? It's not just the delta. It's like how low the sodium is. And
starting from 105 is vastly different than starting from 125.
That's exactly right. Funny that you meant 105 is the kind of the line sound where say, oh, below 105 is a real high risk factor. The thing that makes that kind of a false comparison is you can't control what the sodium starts at, right? That's given to you, right? But presumably you can control the rate of correction. And so, you know, but the potassium stuff, I think the concern there to me is, well, we can correct potassium. And should we? And there's some school of thought saying, well, you need to be incredibly careful about potassium, right? For, you know, every milliliter of potassium chloride is equivalent to about 2 milliliters of 3%. And do you even know how many milliliters of potassium chloride you're given when you say, oh, give them 80 milliequivalents of potassium or 40 milliequivalents in 2 doses, right? You're not even thinking about that, right? And so it usually doesn't get calculated, but that's going to have a pretty profound effect on the sodium. But what I would really like to know is, what is the effect don't tell me the effect on the sodium, right? Tell me the effect on osmotic demyelinating syndrome, right? Because potassium moves into the cell, so that should oppose this cellular dehydration that is the presumable cause of the osmotic demyelinating syndrome, right? That's where that potassium is going to go. And it makes sense that potassium would be hypokalemia would be a risk factor, because that's going to exacerbate that cellular dehydration. It's going to move, you know, as that potassium is leaving the cell, that's water's, you know, because presumably when you're hypokalemic, you're going to shift the potassium from the intracellular compartment to the extracellular compartment, and that's going to bring water, and that'll bring water along with it, which will further dehydrate the cell and cause that collapse and pulling the neuron away from the myelin sheath. So, boy, wouldn't it be good if we did some prospective studies looking at the correction of potassium and what's the effect there? Because I don't think we know. There is a case report of a patient who got osmotic demyelinating syndrome, and the case report describes aggressive correction of potassium, and they tried to draw the conclusion, hey, giving this potassium is equivalent to giving sodium. This is the cause you raise the sodium too fast by giving a lot of potassium. I don't know, one case, maybe that's what happened. I would like to see a little bit more data before concluding that that's truth. Because, like I said, I have models in my mind that seems like it should go the other way. And so I'd like to see additional data. And it's just, I'm not aware of any data that people have looked at this in kind of a systematic way and I think seems like it would be super important. And I think this emphasis only on speed of correction of sodium as the only cause there has resulted us to kind of have blinders and not look at these other factors.
Yeah, Joel, I think that's tremendously important that you outline the fact that like we sort of fixate on the sodium in the context of this condition, and yet there are so many other contributing factors of varying degrees of complexity. I mean, you're not going to be able to fix this person who has suffered from alcoholism for decades. You know, their substrate is going to be very different than someone who is not. And so that's not something that's like a fixed issue now that you're going to have to contend with. But it's very easy, I think, for us to cognitively be like, oh, the sodium's low, we'll just fix it appropriately, whatever appropriate means, and we should be fine. So I guess I'll caveat my earlier statement and say that it's good to know that in a lot of cases, I don't have to agonize over 1 milliequivalent of sodium. But the reality is the issue is so complex, as you've said now multiple times, that there are going to be some people who unfortunately end up with this condition despite our very best efforts. And we just have to do the best we can to mitigate that. Now, Joel, I did want to double click, as Nick likes to say, on this idea of potassium and sodium and the interplay there. So would you feel comfortable at least sort of summarizing some of that pathophysiology for our listeners in regards to potassium repletion and how that's really going to affect the sodium levels?
So have you heard of something called the Edelman formula?
Yes.
I have not. So you're going to be educating me on the Edelman formula.
Edelman did an experiment in 1958 in which he proved using empiric data the Edelman formula working. And it is a super simple formula. It says that the serum sodium is equal to 1.1, which is a constant, times the exchangeable sodium plus the exchangeable potassium divided by total body water minus another small constant of 25. And it doesn't, whatever. So serum sodium is equivalent to the total amount of potassium and sodium in the body divided by the total body water. That's essentially what this thing says. And you can derive this just pen and paper and chalkboard from kind of some basic principles and how sodium and potassium work in the body, and you can get to this formula. And it's not a complex thing. I will provide you a link with a PowerPoint that walks you through it, and you go through it and you make, oh, that makes sense, and you end up with the Edelman formula. What's amazing is that Edelman then did a kind of a big science project in 1958. Like, when I say big science, he fed people sodium isotopes, radioactive sodium isotopes, so that he could then measure exactly how much exchangeable sodium was in the body. Same thing with the potassium, and same thing, he used heavy water, deuterium water, so that you could get it, actually measure the total body
IRB has entered the chat, yeah.
It's amazing, right? Like this is the kind of science that was done in 1958 when I think, we didn't recognize what all these isotopes would do. And then he didn't just analyze like normal healthy people. He's like, who has the most messed up sodium in water? He took heart failure patients and cirrhosis patients. He had patients that had terminal diseases that were dying. And he analyzed all of these patients. And sure enough, this equation that you can calculate on paper lines right up. And it's a really cool paper because there's a couple of figures. He's like, well, what if we just said total exchangeable sodium divided by total body water? No relationship to serum sodium. What about total body potassium to water? No relation to sodium. But if you add the sodium and the potassium together, boom, lines up. It's really a cool paper. But for your point, and what your question was, the take home is these effective osmols, sodium and potassium, they're the same. They have the same effect on serum sodium, both sodium and potassium. Right. And just because the potassium happens to go inside the cell and the sodium organizes outside the cell, because water moves equally between those two compartments, they're equivalent. And so we don't think about them in the same way, but there absolutely are.
Right.
So cool.
when we talk about osmotic demyelinating syndrome in the context of rapid correction of hyponatremia, really it sounds like what we should be talking about it is in the context of rapidly increasing this tonicity, the serum tonicity, irrespective of what the electrolyte is or what the solute is.
Yeah, but you're not going to be able to raise the tonicity without raising serum sodium.
Right.
I mean, that's just right. Even that case report I was describing, like they gave a ton of potassium, and you watch the sodium rise. They're like, "Wow, why is the sodium going up? We're not giving the patient any sodium." Well, they were giving them a lot of potassium, and that's that as that potassium moves into the cell, well, sodium is going to get exchanged in the other way around, or water is going to go with that, and that's going to raise the sodium concentration. There's a couple of different explanations for why that sodium goes up, but the reality is if you're raising the tonicity, that serum sodium's going up. It can't happen otherwise.
Yep.
I think my sort of practical takeaway from this is to remember that it's still going to be important to correct a very low potassium in these patients. Like if they come in and they have a potassium of 2 point something with EKG changes, we got to treat that. But this is not a circumstance to try to gild the lily and like turn a potassium of like 3.4 into 3.6. That we can slow our roll a little bit here when we're trying to tightly control sodium. We should also be mindful of potassium.
Yeah, that's exactly right.
So, Joel, I know we want to talk about the Ddavp clamp and spend some time discussing that. But before we do, let's take another look at the case that we kind of described earlier. And let's say instead of a sodium of 114, 116, their sodium's 108. So they're closer to that really worrisome level, sodium level. And, you see them initially, they look, they're confused. They're a little disoriented in as opposed to the previous case. You step out of the room and now they seize. So what is the next step to safely try to treat that patient? Obviously, we're going to assume the seizure is related to the hyponatremia.
Yeah, that's right. So you got a patient with sodium 108 and they seize in front of your face. And so you're going to give them hypertonic saline. And so I use the European guidelines. I give them 150 cc's of 3% saline. Check the serum sodium. Don't wait for that serum sodium. Give them another 150 cc's of that. So you give them 300 cc's of 3% saline if they're a normal-sized human. And the American guidelines are give them 100 cc's of 3%, stop seizing. Nope, give them another. And then they say go ahead and give 300, kind of like that. Boom, 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 boom. It's actually 300 cc's over an hour. You do it every 20 minutes. And again, there's no data to support one or the other. We have data from the neurosurgery literature that says that it's safe to raise the sodium by 5 points, and that usually will eliminate increased intracranial pressure, which is what our goals are. And so I think we can extrapolate from that data that that's the appropriate way to handle that. And I don't think there's a lot of controversy here and a lot of debate. It seems to work, and so people take this up. Do you guys see any other standards of being used or?
Yeah, so I mean that's in line with what I've seen, and I guess my approach is like if you do encounter this scenario, once the dust is settled from the seizure, then you would go about treating their hyponatremia along the lines of what we've discussed before.
I think the key sort of point to emphasize here is that this is the exception to the rule. This is the situation where the person is in danger because of hyponatremia, and you do actually need to correct them quickly, but in a very controlled way, and then revert back to controlled correction.
Yep.
Yeah, that's right.
Perfect. And that's exactly, Joel, thanks for entertaining that question. I really wanted to make sure that we explicitly hit that nail on the head, because I know that folks are going to wonder, okay, like how does this differ from our severe hyponatremic patient who is not seizing?
Yeah.
So perfect. Nick, do you want to introduce the all-important, all-exciting Ddavp clamp? Is this a good time to do that?
Yes, I think that's probably one of the most important things that we can talk about in this show, because I think a lot of our listeners embrace this concept. And the idea here is that sometimes our concern is that somebody starts to correct at an appropriate rate and then they start to overcorrect. And then instead of giving them saline, we have to give them free water to sort of offset this rise. That their osmostat is reset, I suppose. And we need to prevent them from causing harm as that happens. And the idea is that if you give Ddavp, you can basically, to use your buckets, Joel, you could put them into a high AVP state, and you can prevent them from rising. Do you think, first of all, do you think this makes sense physiologically? And second, is this an approach you use?
Yes to both those, right?
Okay.
And so, yeah, no, you nailed it. That what happens is these people overcorrect. Why? Because they were in a high ADH state and you corrected that, right? You either gave them cortisol and you corrected their adrenal insufficiency, or you replaced their volume, right? So they're no longer hypovolemic, or somehow fixed their heart failure, or magically corrected their, or magically corrected the cirrhosis, otherwise known as liver transplant, right? Like there are situations where we can change the basic physiology of these patients, and all of a sudden their ADH levels go to zero. And they start making a large amount of dilute urine, and they're going to correct their sodium way too fast. Or it could be someone who's drinking a lot of water, and all of a sudden you've restricted their water intake. Though those patients tend to be acute, and we're less concerned about those patients. So they'll be acute hyponatremia. They tend to have lower risk of osmotic demyelination syndrome. And so what we do is to say, and then there's a couple ways to handle this. One, you have the reactive approach where you kind of watch the patient. You start seeing this before your eyes, like, oh my God, they're making 400 cc's of urine an hour or 1,200 cc's of urine an hour. Let's give them some DDAVP and slow that down. That's a reactive strategy. Or you say, I don't know exactly what's happening, but I don't want to worry about this. Right? I don't want to be having to check in on this patient every hour. I'm just going to start them on DDAVP. And if they already have a lot of DDAVP or ADH on board, giving them more is not going to change the situation. I'm just going to prevent it from falling. And so we'll give them DDAVP. And then the thing to remember in this situation, though, is once you give them that much DDAVP, they're not going to respond to saline. You're going to have to, you're forcing yourself into using 3% saline to fix their sodium at that point.
Great point. So in somebody like this patient, this person who comes in with a sodium in the low teens, who's altered, who's got some other comorbidities that put them at risk, is this somebody where you'd sort of err towards proactive Ddavp clamp or more reactive?
Yeah, I mean, I look at that data on the percentage of patients that get overcorrected by standard guidelines, and it's such a high rate. My sense is we're really bad at this, right? Like, and I don't think that it's we're just not, these are 40%, these are just bad doctors. I just think this is harder than we expected. And you guys have all lived the reasons it's difficult. Like the lab doesn't get drawn on time. The nurse doesn't report the increased urine output, or the patient, it wasn't, there's no Foley, so we don't even measure the increased urine output. The patient's using the bathroom, right? People, there's all kinds of reasons why this kind of things happen. And I'd rather just let's take out the risk. And let's avoid having to go there and be as careful as we can. And again, I think you need to use this selectively. Like the patient's sodium is 122, and they're at very low risk for this asthma. They got a normal potassium. They're well nourished, right? You're not going to run into this problem. Just go ahead and correct their sodium slower. It's the patient where you're like, yeah, if this patient corrects too fast, I'm going to be in a lot of trouble. Right, it's the alcoholic patient. It's the patient with hypokalemia. It's the patient who's malnourished with cirrhosis. Those are the patients that I get real worried about.
So Joel, just to be granular about this, with that proactive strategy, that's that Q8 hour dosing of DDAVP that you're giving. It's like I think two micrograms every 8 hours, as I recall.
2 micrograms every 8 hours. Yep.
Perfect. Okay, and then again to double click on the point that you made. The folks that I remember being at highest risk, those like your heart failure patients, but then also those folks that truly have hyponatremia in the setting of volume depletion, you replete them, they can very quickly start putting out that dilute urine, and it can become very problematic very quickly. I think that's what I recall, at least from when I reviewed this the last time.
It's your thiazides and your volume depletion patients that are the ones that are going to correct the most quickly and are going to be the highest risk. I wouldn't say the heart failure patients. Those heart failure patients, they actually usually do not get severe hyponatremia. Those are going to be floating around the high 120s, mid 120s. I have not seen them get into trouble. I'm sure there's exceptions, and happy to deal with those on a case by case basis. But those are not the ones that I get real worried about. And then the other high risk group is hyponatremic patients that go for liver transplant, and they got a lot of things going on there. But there's a number of case reports getting in trouble there. And then the other one hemodialysis patients that have severe hyponatremia, because there's nothing fixes the sodium quite as fast as hemodialysis. Like that'll bring in the 4-hour treatment, they'll go from 118 to 135 like that.
Now, presumably in that setting, the risk is different though, because you're also removing other things like urea, right? So it's complicated, I guess.
That's a great way of putting it. It is complicated, and it is complicated. There's some interesting animal data that shows that that uremic state is somewhat protective. The movement of urea is also can also be somewhat protective. They get relatively high urea intracellularly, which moves water into the cell, kind of opposing that cellular dehydration that you're worried about. So yeah, lots of things going on there. It's complicated, but there's but this is an area where you got a patient who needs dialysis, and how are you going to provide it? Because you're going to raise that sodium pretty quickly with the machine, so you got to be careful.
I think it's complicated could be the motto of the field of nephrology.
We like to keep you thinking that.
Just one point that I've gotten pushback on before when using a Ddavp clamp is people are like, wait, that's expensive. And, just to push back on that a little bit, first of all, it's not that expensive, right? I mean, I looked this up before we recorded, and it looked like, 2 days worth of Ddavp costs about $50. So it's not actually that expensive. But more importantly, like, if somebody overcorrects too quickly and then you're having to give them a bunch of free water and they stay in the ICU much longer, like that's expensive too. And so I think, Ddavp is not just a safety feature. It prevents you from causing this harm, but it's also like probably a more efficient way to fix this problem in some people, especially those who are highest risk.
So there was a review, meta-analysis by Macmillan that looked at Ddavp use, and pulling the trigger and using Ddavp is gonna result in slower correction of hyponatremia versus not, right? I mean, that's kind of the point of the drug, right? And that slower correction can mean longer days in the ICU. So I think the expense is not so much the drug, it's that extra day or two in the ICU. Now, again, your point, Nick, is that, well, if you overcorrect and then you have to relower them, that's showing a lot of concern. And I think a lot of people just correct it and they're like, okay, they're out, they're done, and cross your fingers. And most times you'll get away with it. And probably not the best way to practice medicine, but it will get them out of the ICU quicker.
Two other Ddavp related questions that I have. We talked about the proactive strategy as probably being the one we should lean on more commonly than the reactive strategy. If we find ourselves in a position where we have to be reactive, how is that Ddavp dosed in that circumstance? Is it a different approach, or do you just kind of start it later once you recognize what's happening?
You start it later. Yeah.
Okay.
Yeah, and I think that's actually a good point, is that once you start the Ddavp strategy, whether it's reactive or proactive, you stay on that boat until the sodium is above 125. Like, the way you're going to adjust the sodium is by adjusting the 3%. Don't start manipulating. Oh, I'm going to skip a dose of Ddavp. Then you have no idea what's going on. The half-life of this is not entirely reliable. Like, I just tell my fellows, hey, once we start Ddavp, you keep dosing it. You don't stop until their sodium is 125, and you go from there. That there was recently an abstract. We just had our national meeting a couple months ago, and there was a oral abstract on comparing a reactive to Ddavp clamp prospective trial, and there was no difference there. They seemed to be, again, and it was only 25 in each arm. It's not this huge thing, but it was randomized, and they didn't find a difference in terms of speed overcorrection. Speed of correction was actually faster with a proactive strategy, which didn't quite make sense to me. It didn't seem right, but that's what they found.
Interesting. And I guess that actually answers my second question of like, okay, when do we stop the Ddavp clamp? I'm hearing 125 milliequivalents is kind of when you probably stop it and then just treat based on the the labs that you're getting and the patient.
At that point, you're at low risk.
Perfect. Okay. Awesome, Joel. Thanks for getting granular on those topics.
And I don't think I need to mention this, but I just want to make sure, like, do not mix DDAVP with tolvaptan. Nobody knows what happens there. Like, you're way off the way. That's a strange place to be. You don't want don't do that.
That's like the, what was it, like the candy that if you ate too much of it as a kid, your head exploded. That was the myth.
Pop rocks.
Pop rocks. Yeah.
It's the saline plus furosemide thing. Who knows what's happening there, right?
No bolaresis.
Yeah, and I think there's a reason. I think there's a reason why Vaptans were not included in this discussion. It's like I've never used one. I mean, I know you have, Joel, but it's, I don't know, not commonplace for me.
They're pretty cool drug. I mean, they really work. I don't think they have a place in this severe hyponatremia because they really work, but it's kind of a crapshoot how much they work. And they oftentimes, about a third of the time with standard dosing, will overcorrect. Mostly in SIADH. If you use it in heart failure, they don't tend to overcorrect. Only about 4% of them will overcorrect with that standard 15 milligram dose. But with SIADH, it's about a third of patients will overcorrect with that 15 milligram dose. So I don't use a 15 milligram dose. I use a 7.5 milligram dose. But they do work. They are, and sometimes, like, you get this consult for a patient who's got a sodium 122, and they're like, yeah, we want to take him for a procedure, and anesthesia won't let us take him if sodium's not 130. Like, you literally, the consult is make this patient sodium 130, as quickly and safely as possible, right? And tolvaptan will get the job done, especially in a heart failure or cirrhosis patient, where if you give them 3%, that's headed. If you give 3% in the heart failure patient, it's going right for the lungs, and if you give 3% in the cirrhosis patient, it's going right into the belly. And I hate doing that, right? You're just causing another problem. And the tolvaptan works real well there. That said, we don't typically use tolvaptan in patients with liver disease because of a black box warning about not fulminant liver disease, but elevated liver enzymes. Concern there. Got it.
I think I just want to ask you one more controversy, or sort of one more sort of point that's often confusing. So we've been talking all this time about the acute hyponatremic patient, but what about the chronically hyponatremic person? Let's imagine somebody who was admitted last week with a sodium 115. They left the hospital with a sodium of 125, and now they're back and their sodium is 112. But this time they've fallen and they have a big subdural. So normally, neurosurgery is telling us we should get their sodium level up to 145 to 150. But, first of all, is that excessive? And second of all, how do you approach the chronic hyponatremia person different?
A lot of stuff we were talking about before. If it's truly acute, like the classic acute hyponatremia is the marathon runner, right? The patient has a sodium that's totally normal, and they start running a marathon. They get this non-osmotic release of ADH. They retain all the water, and their sodium drops 20 points during the marathon. And then they have a seizure in the middle of the marathon. Those are the patients. They're at very low risk of osmotic demyelination syndrome. You just go ahead and give them 3% and fix them quickly to stop their seizures.
Yep, I saw this exact case in the New York City Marathon. That's exactly right.
Right. And in fact, they're trained when they see a patient seize on the course just to give hypertonic saline, no testing. Right. That's just the most common cause. And hopefully they don't have epilepsy, I presume. Right. And then the other one that'd be another classic one would be MDMA exposure causes an SIADH. Oftentimes these hot dance halls, they'll be drinking a lot of water. They also get acute hyponatremia. Same thing with the marathon. Go ahead and give them hypertonic saline. Don't really need to worry about speed of correction. It's very acute. Patients, when we had ODS, we're assuming that they have chronic, right? Because what you need is that intracellular environment to have adjusted to the hyponatremia. Now, the story you're giving is a patient that I'm quite concerned about because their sodium is so low. The subdural hematoma certainly makes the patient at increased risk for neurologic consequences. In this case, I would go with an acute increase in sodium of 5 points to lower the intracranial pressure, and then I'd give it another 24 hours, and then I'd just go again, and I would kind of step it up and not stop at 125, just keep on going until you got it up to 145 or 150 is whatever neurosurgery is asking for. But I think you can't get there fast. I think you need to go day by day.
Great. Perfect.
That's Wow. Yeah, that's a tough one, Nick. And Joel, you, I think, definitely hit the nail on the head.
Hit that curveball.
So,
thank you.
Yeah, impressive.
Any closing thoughts, Joel? Any other things that you think people shouldn't do or should do always? Parting wisdom.
We have a sense in medicine to when we read it in a textbook, it feels like it's dogma, that this is the way it is. And I think that the sodium chapter, though we have not finished this. There are still things that we do not know about sodium, and we should come at this topic with a little bit more humility and a little bit more understanding that, hey, this stuff is hard. It's not all figured out. We're doing the best we can, and kind of understand that, we're not great at it, that we have a lot of room to improve. When we're talking about 40% of patients are exceeding that target rate of correction, maybe we need to kind of rethink how we're teaching this and how we're dealing with this. I guess that would be my thought there.
Joel, I feel like you have taught me a lot, and I usually think of myself as a pretty humble clinician, but now that humility is at an all-time high. So thank you for that, Joel, and I think my future patients will thank you. We're going to go into our conclusion here in just a minute, but before we do, Joel, anything you want to plug in particular for our audience?
Yeah, NephJC, we meet twice a month. We do just an online journal club. If Twitter's not your thing, that's totally cool. We have a cool website, nephjc.com, where we take apart a manuscript 2 times a month, and we do a summary of it. We include a visual abstract. We do a summary of the discussion, the Twitter discussion. We come up with that later on. And when we got our act together, we do a podcast on them also. So it's kind of if you want to keep up on literature, and it's a lot of, we do not only nephrology, but we also do hypertension and transplant. So I know it's all nephrology. It's just nephrology.
Awesome. Awesome. So NephJC then for our listeners. Beautiful.
Yeah, that would be awesome. Yeah.
Cool. Awesome.
All right. Well, thanks again, Joel. It's been great having you. And with that, we come to the part of the show where we like to say thanks. Thanks to Joel for joining us today. Thanks to the people who left us reviews, comments, or given us a shout out on social media. We really appreciate all of your kind words and feedback. We listen to you. We actually make episodes based on the feedback you give us. If you haven't so far, please leave us a 5-star review on your favorite podcast app. That helps other people find us. And feel free to send us messages. You can message us the podcast at CritCareTime on Twitter, or you can do individually at Nick M. Mark or at Askins_Razor. And finally, you can follow us on Threads, Instagram, and YouTube, etc. Finally, go to our website. We have lots of great content there. All the papers that you heard Joel refer to are there, for your perusal.
Beautiful. Absolutely. And of course, feel free to follow and engage with Joel. He is at kidney_boy on Twitter. And now we'd also like to give a big thanks to our sponsor, C-Star Medical. We are fortunate and grateful that this episode and all episodes in season 1 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, C-Star Medical. That's SEASTARMEDICAL.com to learn more.
And then finally, before we go, we'd like to thank the members of our team who make this show possible, who had some great suggestions for this episode. Our production team over at Podpaste does an amazing job of editing out all of our stumbles. And last but certainly not least, Kurt Belknap for our awesome theme music, which is playing right now. Disclaimer time. So this podcast and all related media, including but not limited to animations, graphics, and videos, are the property of Critical Care Time. Please share our content. We just ask that you cite our source.
And of course, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. One more time, Joel, thank you so much for your expertise and your time. We're so glad we were able to get this done. With that, thank you for listening. I am once again and always will be Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thanks, everybody, and thanks a lot, Joel.